So, so the plan here for the first half hour is to review theory and get a chance to talk about case experiences you're having. And I've had a chance to talk with some people and see some cases that people have had. And it seems to be helping them out to think about these categorizations and processes and timing and things. So I'm going to go over that once again in a review, and then we'll add in case issues that you want to talk about as well. So I'm going to start with the share screen. So here we go. So starting off again, we're working with people who have insecure attachments or disorganized attachments, trauma of early neglect, abuse, invalidation, parental splitting, projecting on the child, producing primitive, painful feelings, primitive rage and guilt about the rage, and then making a sort of a fragmented state, a self-destructive system, symptoms and various things. And we have this spectrum of fragility. So we have a spectrum whereby on the one side is mild fragility, where the person can tense up and isolate affect up to a mid-rise, a moderate level of rise without getting too much difficulty. But then above that go to either repression, confusion, or projective processes. And at the other end, it's severe fragility. The person is mostly operating in projected processes, where parts of themselves or modes are projected and experienced, and projection as a defense and cognitive disruption. So mainly operating up here. And then moderate fragility is somewhere in between, where there's some ability to hold, intellectualize, and tense up. But above that, all these problems start to come in. A second here. To do something to turn off the. There we are. Okay, so another way to think of it is up here is split parts. What's happening here? And so up here is split parts or modes: projection, disruption, repression, isolation of affect when everything is calmest, and with the mild fragile person. And the other way to think about it is I think someone has hit the closed captioning. Please don't turn on the closed captioning. Can you turn it off, whoever turned it on? Or Chris, if you can find out how to just disable that for me.
Yeah, I gotta look.
All right, so it can't be, you can't do closed captioning because it's got patient material coming through and people are going to talk about their cases, same as recording. Okay. What happened? So the other way to think about it is that when there's a rise in feelings in the more severe fragility person, they shoot up quickly into split parts or projection. When there's more moderate fragility and going this way, they shoot more into cognitive disruption and projection. Over here, they can shoot more to repression and cognitive disruption. And then when they're over here, they tend to go to isolation of affect and muscle tension. So we want to aim to get over here so that there's the potential for the alliance to start to work and the unconscious to start to be able to be accessible. This is another way to say the same thing. And another way to think about is certain emotions are accessible below the threshold. Person can start to feel some of these feelings, including the positive feeling and grief. Those are easiest to feel. But even when they feel those, or especially when they feel positive feelings and grief, the rage and guilt go up over threshold and cause whatever symptoms they have up there. So here it would cause cognitive disruption and projection. So positive feeling, bit of grief, and that next thing is they think you're angry at them, or start to perceive you in a certain mode or get very confused. But when you get down here, then more likely what happens is they can have some positive feeling, some grief, and some of the rage comes up but goes into the stomach, makes repression, And then when the guilt comes, they get confusion. So then, and versus further over, they can start to feel some of all these feelings. That's where you're trying to aim, is over here. So to do that, we have to build capacity. We have to raise this threshold and build capacity. So that's what we're going to talk about here a bit. But about this capacity building phases. And the two here include psychic integration and stabilization as one phase, and then versus graded format. So with psychic integration, you're building the early reflective capacity, the ability to observe processes, to overcome projection and impulsivity and regressive phenomena. It might take a few sessions, it might take 6 months, depends on how fragile, how disorganized, how much fragmentation is in the person. Versus graded format, you start to see early signs of UTA, some early breakthroughs, you see muscle tension and isolation of affect coming in. So this is the way I sort of have broken it out, is in two broad sections here. Is the sort of to moderate fragility, it's more stabilization and integration, because over here, the patient can quite easily go into split modes, projected processes, or disorganized. When you get over here, they have some capacity to observe the processes, hold anxiety, muscle tension, and feel some of the emotions. So it's a lot better situation when you can get over here. That's where we aim for. So another way to think about it is this metaphor of a person in the ocean who's drowning needs some stabilization. They don't need to, this person here is not ready to talk about the childhood, let's put it that way. They want to talk about oxygen. They want to keep their head above the water, at least. They need something to hold on to, and they need something to sit on and float on this ocean before they can eventually have a stable base of some sort to be ready to tolerate and face the unconscious. So how do we get there? Is we build connections. And connections are links. And these are examples of links. So a link between feelings and anxiety, feelings making defenses, anxiety making defenses, the transference current relationship, how they relate to each other, how the transference in the past relate, how the past and the current relate, how attachment is related to separation, and that's related to fear and grief, and that's related to rage, and that's related to guilt, how these are all connected together, how feelings on the inside relate to feelings on the outside, how split parts or modes inside relate to the same thing outside, how past parts or modes relate to current, and how current relates to the transference, how these all occur everywhere, past and present. And these are connections that build ability to reflect and observe and understand what's happening. So this is what your job is in the early process, and we're mostly through that with her at this point, linking things, and it also helps them observe projected processes, observe split modes, observe body response, label things, and you're ending up with a more integrated person who has self-reflective ability. And it does involve different brain regions and functions based on some research of treatments similar to ours. So when a person is really distressed, the person cannot tolerate being held for a long recap. Think about a long recap. A long recap is you take 10 minutes and you review how the pain of the trauma, the rage, the guilt, grief turn into anxiety and get transferred forward and turn into defenses, and the self-destructive nature of it, and how that works in the current life, how that works in the room, how it worked in the past. Got a big story in it. To be able to tolerate a long recap, the person needs good anxiety tolerance. Because think about it, you're holding them to look at their whole self for some minutes in a row. If you want to test how fragile a person is, try a long recap, and you'll see how fragile they are. Because if a person even is moderately fragile and you try a long recap, they'll disorganize or they'll project. They think you attacked them. They won't be able to incorporate it. So what I find in again studying the videos is that quick links, single links, where you connect one thing to another, is tolerable for a person when they're disorganized. But one thing connect one thing to another thing, and it works way better than a long recap. This what it does is it helps them learn to intellectualize, how to rationalize, how to connect things. It also shows them that you're willing to help, but you're not going to control them. And that is a fine line to walk when a person's been very much controlled and abused by others. You're going to help them see bits, but you're not going to control them, or you're not going to force them, quotes, to look at the whole thing. Another way to think of it is like this. This person here is drowning. If I'm going to throw him a raft, he might drown because of the raft. If I throw him a raft, if he has no ability to even hold on to the raft, what I'm going to do first is throw him some sticks. Anxiety, fear makes, your body do this. Fear, anxiety makes you tend to avoid things. What happens in your current life seems to come up here with me too. These kind of connections, single connections, eventually become a bunch of sticks that they can hold on to, like a bundle of sticks. And now he's not drowning anymore. And then you can use these bundles to make a raft. So think about this is probably on a brain structural level, really what you're doing. And then you get a stabilized person who has some tension, some ability to look up at the processes and isolate affect. So to do that, we need a stance that's going to be helpful. Now, the general stance of the therapist doing this work is present and engaged. Okay, you're there. You're not a cold, neutral person, but you're also not overly in there feeling bad for them or really encouraging them. You're just there, engaged and present. You're validating everything. You're integrating things. You're helping how all these things work. You're not splitting. You're not doing rescuing. You're not doing idealizing. You're not devaluing. You're not devaluing yourself. You're not devaluing the patient. You're not controlling the patient. You're not over-controlling yourself. You're not submitting to the patient. You're not letting the patient control you and make you submit to them. So do you understand what I'm getting at? The kind of like you're in the middle, seeing everything, helping them realize how they tend to operate, help them realize it makes sense how they learn to operate based on life, and to be able to see how that flows in current life, in the movement, in the present, and also in the past. You're ready to link and understand things. You're in reflective mode. The other thing is your stance is a little bit looking ahead at what's coming next. So you're in this moment and you're looking at what's probably going to come next. So for example, positive feeling comes with you. You're now questioning where is it going to go because of the positive feeling, and you're watching, and then they get confused. Now you know that's coming. So when the positive feeling comes, you say, so what does it do when you have a good feeling with me? And they're already confused and you're watching it. So so to do this, being a little bit ahead, you have to understand all these things I'm talking about. And I'll tell you, the people I've talked to that have been incorporating this, they find it hugely helpful to be doing these things and seeing what's happening and looking a little bit ahead, okay? So next piece is around, there's maybe some questions. Okay. All right. So projection, how to detect projection. The person tells you that they think you're angry at them. They're afraid. Their face shows fear. They're trembling with fear, for example. They might react with anger at you based on thinking you're angry at them, like getting hostile. Those are some things that you can see when there's projection. So how to handle projection then? You can ask them how they think you think. Ask them how they think you feel. Ask them how they interpret you. Reflect on the thought content. Ask where these ideas come from. like in their life, where the idea comes from that you would control or do something to them or something like that. Try to regulate down the anxiety. You could try a little bit to notice the body focus of the anxiety. Just notice the body to settle. That can do something to help. You can behave differently than the projection to break the projection. So one projection is that you're a cold, detached person, and you break it by being active, speaking, engaged, and asking about things. You're doing the opposite of something different than what the projection is. So the thing is, you're being different than the projection. So the opposite of what I'm talking about here would be the patient projects that you're a cold person and start to react to the projection that you're a cold person. You don't want to become more cold and frozen because that will confirm the projection, okay? You want to stay in the middle and help them see the projection, okay? You don't want to become any part of these projections, but you're there to help see all these things. And the other thing is watch for the anxiety to go into confusion. When you neutralize projection, the anxiety will tend to go into cognitive disruption. So the vision blurs and things like this. And then do a recap after things get settled to talk about all these things. A little bit then about split parts and modes. You know, these characteristics are inside, they're in the past, they're in the present, or they see them in the transference. They interact from inside to outside. So these are the parts inside, they interact with these same parts in the world out there. So perceive this one thing. Perceive one thing and then interact with it either with a matching part or with a different part. So for example, they might project hostile, the hostile box here, and then react with hostile. So then there's a physical fight or yelling, arguing. They may project passive victim and go to hostile. Then that's going to be, the patient becomes abusive of the other person. Then it could be passive, a victim to victim. So then the two people are together, aligned that they're victims together and support each other as victims of a third person who's this brown box or black box or whatever, gray box. Then you have, then it could be a different category. So this could be controller. Person goes to controller, the other person can go to controller, and then the two are arguing for control. Or controller can go to see aggressor and then become controlling of the aggressor. The other person is going to feel angry about being controlled. So it's going to actually reinforce the person getting aggressive. And the other thing is, this all can happen inside the person within the self. So this part can go against that part, can go against this part. These all can happen inside of a person as well. So what you're doing here is helping them recognize the patterns of how they tend to interpret people's actions in these categories and how they interact with one another. And as you do it, again, you're going to tend to see, you're going to help understand how they work inside, outside, past origins, how they interact. You're going to help them see the second when one mode shifts to another mode, when there's an overlap period. So for example, when they walk in your office, they don't know if you're going to be a controller or a neglector. They don't know which one. And in that moment in between them, if you say, so you're not sure if I'm going to do one or the other, they get very anxious. Because remember, the defense of this mode splitting and such prevents cognitive disruption. That's the function of it. So when you interrupt it, it's going to cause some drifting, okay, and some other rotation of defenses. So let's see, I'm just going to go through a few more and then we'll go with some questions here. So the guilt immersive approach, super helpful. I think it's one of the most important things that I've been able to figure out and discern from this work is that the integrating of lit off projected rage And positive hope or positive feelings mashed together makes anxiety. And that anxiety, if you can get to integrate the mixed feelings and make a higher threshold of anxiety tolerance. So pressing on the guilt after the rage comes, and then the anxiety can go into the striated muscle would be great. Sometimes it'll go to nausea. Sometimes it'll just go to confusion at first. Depends on where you are relative to the thresholds. So if I move this up to here. So here, if you're doing the guilt immersion with projective processes here, it might just go that they get confused. But when you go a little further, they might go into nausea. They go from projection to nausea. And when they got more capacity, you see, then you're going into striated muscle. You're going over here. So it depends on where you're at as far as rise in capacity. So guilt immersion, huge, huge key. So your jobs up here, integrate the split parts when you're up here, handle projection when you're here, regulate anxiety, overcome repression by recapping, and bring rise. When you're down here, you start to press and mobilize, or brace up and mobilize the complex feelings to get things going more further upward. So your job changes as you go across here. But in one session, you might have to do all of these things. It can happen. You have a session where you have to handle projection, regulate anxiety, deal with repression, and still press. So you got to be ready to be flexible and go with what's happening in front of you. And to do that, we got to be comfortable to get to know what's happening in front of us. And to do that, we have to get to know our patient and how they tend to look when they're doing different things. We have to know how they look when they're in projection, how they look when they're in disruption, how they look when they're in repression, and how they look when they're tense and defending. Okay. So that's a whole bunch of stuff. You know, I like the spectrum, and again, I've seen some people's work since starting this, and this little menu is useful. Angry face, angry words, intimidating posture, shaking a person, striking, kicking, punching, murders, animal rage, torturous rage, right? You got to decide where you can go, you know, where the patient can go, what's tolerable. So this little menu thing is great. And this is another huge piece here, is identifying the cycles. This thing here, if you map it out with your patient, it's hugely helpful for us and the patient. And you'll see, I've been doing this with the patient we were working with here to help her see these cycles. And she talks about that she's studying the cycles, how it goes. So the cycle can start anywhere. Say it starts with the projection of critic, then there's fear of the critic, then it goes into pleasing mode, or it goes to rage toward the critic. The guilt is repressed, makes more projection. And that can go around and around until the person may go into shame, self-hatred, passing out, suicidal state, you know, go to repression, depression, you know, physical symptoms from that. Or they can get stuck in this exhausting pleasing mode. And that's the, you know, this patient has all these different things. And the ultimate way to thwart the cycle is to recognize the guilt. To recognize they don't want to harm the critic. They don't want to harm anybody. Recognize that there's mixed feelings inside that causes this whole thing to keep going. That they care about people, right? That they have good intentions, even though they have plenty of rage too. Knowing that is huge. Huge for a person who is constantly afraid of being a torturer or that they're going to be tortured. When they know they have guilt about their rage, and that's again why this is about guilt. Capacity to tolerate and be aware of the guilt about the rage, then they can break this cycle. They don't need to do anything to themselves, and they don't need to project. And they don't need to please. It's huge. Okay, so these things, each of these diagrams, you know, and then graded format, and you understand this is easy stuff. In a sense, this is sort of something that becomes an easier process. You know, you brace or press up, you recap, you press, recap, press, recap. Then you look for unconscious alliance to start kicking in. And when the threshold's high enough, you get unconscious alliance doing its thing, bringing linkages, bringing negation, bringing good links of unlocking and images. But you got to get going up there to start seeing these things. All right, so that's an overall review. And I know some people are just coming in. As I said, I'm going to put this whole thing up. This is probably one of the main go-to reviews that I think I'll call it that. I'll call it the big review or something. It'll be on the website that you'll have access to for people that couldn't get in this first half hour. So let's go with some questions. There are a few questions on the chat coming up. Eveline, when they make these projections, is it triggered by something in reality? By the outside? It can be triggered by something outside, or it can be triggered by nothing outside. It can be triggered just by an inside event. So, for example, one of their friends expresses a positive feeling for them, then they go to projection that they're going to be criticized by that person. That's not coming from anything that anyone did. It's purely an inside operation because of the feelings. So Randy's comment, what do you do if rage is directed toward an organization or an aspect of culture? These things, these structures all come from people. So there's always people that are in these, structures, these buildings, these organizations, governments, culture pieces, it's people. So this is where you can focus on it as if it's a person. It's the same as we talked about before about anger at a church or a religious structure, and how that God or other deities or leaders of these structures become figures that bring all the attachment feelings up. So you can work on that with a person as if that's a person. So Anna, about if a person gets into a suicidal state. So the way, suicidal state, if I go back to this diagram, they're inevitably triggered by some of these processes. So the way to deal with that is to help them see this process, first of all. The other place that suicidal ideation can come from is a lack of hope. Lack of hope comes when the person can't see any progression or can't see what they're trying to do in their treatment. So they don't see a pathway forward. So with the way we're working in this treatment approach, it's always working with a pathway forward. And so it therefore always tends to be building hope. They can see what they're doing. They can see a way forward. Now, what about someone who's severely disorganized and continually self-injuring and in and out of hospital and suicide attempts and substance use, and you're not even sure that they're not psychotic? I mean, someone who's in a severe disorganized, fragmented state. Those patients may or may not be able to be a candidate for this treatment, because this person, to do this work, you have to have someone that can go home and live a life and then come back one hour a week or things like this. So that person might at first be stabilized by medical management and day programs or day hospitals or public clinics where they can go to drop-in centers. They can use some of these principles, but they need maybe some structure. Depends on how bad it is. Okay, overcoming repression is recapping after the process has been identified. So it's basically the person gets nauseated and then you intellectualize about it. So it's recapping. Okay. So everyone's question is, when someone goes from split parts or split modes into more CPD, so when they move from here over to here more, question is, are they more at risk of accidents and forgetting important things? I don't find that at all. I don't find that I don't remember people getting like sitting in this cognitive disruption fog in the real world out there. I don't find that too much. Okay. Because what happens in the real world, they're driving the car, they project then, and they stay alert. Okay. They don't tend to stay in a big dissociative state when they're trying to drive a car when you're working this way to build capacity. The other place that they can go is down here and have tension in the muscles and their head stays clear when they're doing tasks that are relatively not too pressurized. They can be tense and do the task. So I don't find it a thing that, and I don't find it something I have to worry, like warn people about or anything. But I do explain it to people. I say, that they say they're more nauseated. And I say, and I might remind them about the pathways: muscle tension, smooth muscle, cognitive disruption, and fear. I call this just up here, I call it fear. So 1, 2, 3, 4. I say, so when your anxiety tolerance gets better, you might notice these things a bit more. You might notice more muscle tension. But when your muscles are tense, your head is clear. When your stomach's cramped, your head is clear. Okay, I just go over that in the recapping, help them learn about that. Any other questions that people have?
Just would like to say that I find it really helpful to use ISTDP also for inpatients. Maybe yes. Patients can't use it, or it's not the only treatment they get, but it's sometimes a great combination. For example, I work together with physical therapists, and if people have problems locating their nauseous feelings or stuff like this, I can work more on an ISTDP setting with them, and the physical therapist works on a physical level with them. It can be a great combination.
Absolutely. That's a different situation when if you have the backup of a ward, then yes, you can work with these patients, all these patients, people that have some psychotic process, and people with severe depression that are in the hospital, like really depressed. You can work with them in there, and we have a lot of outcome data on that we've published and showing reduction of electroconvulsive therapy and things. So it's definitely usable on the ward. So that's good. About chronic fatigue, someone asked. So chronic fatigue is a mixed bag of conditions. It can be related to repression. It can be related to cognitive disruption, because often with chronic fatigue, there's a thing called brain fog. There tends to be fearfulness as well and mistrust of the system, and explaining it by environmental factors. So the person becomes afraid of certain things they can smell out there. And it's very disturbing and frightening when there's certain things in the air they can smell or they think are there or that are there. So then that causes a bunch of anxiety. So these kind of conditions definitely can be, the person can benefit from this. There's one person who was on the newspaper article in our one of our national papers here, had that problem, and she talked a bit about it in that article. And I mean, for her, she was having, she fainted when they brought in a new piece of furniture because the smell off the furniture. She went unconscious, and a few other people got dizzy, and then everyone was thinking there's some chemical. And she had a ton of very disturbing symptoms and bad depression and paranoid ideas, and she was over here. And we got over here, and she had some repeated unlocking, and then, she talked about 16 years later, no symptoms, she's been doing well. And I think we had 40 sessions or something. So it's possible to work with those populations. Sometimes the person with that problem actually is delusional and with a psychosis, and you might need medications as well, or instead. So you have to assess each person. Okay, Randy, I have a few patients who just want to push the perpetrator away when we're processing anger. And I'm finding it makes it hard to access guilt. Pushing away the perpetrator, what do you mean? So then when the rage comes, they just push the person away? Is that what you mean, Randy?
Yeah, they mentioned, they just want to get, they say, I don't want to hit this person. I just want distance. I just want to get away. I want them to be away from me. And so
usually that means they're not experiencing the rage then in their body. Okay. That's usually what it means. Because ultimately it's a defense. If they have a murderous rage, it's a defense to push them away. If they feel murderous and then they push them away, it protects them.
And so
it's-
we're not fully accessing the rage, is what you're saying, or?
Yeah, it sounds like it's probably not in the body, because when it's in the body, they want to do something.
Yeah.
Yeah.
Okay.
Okay. Yeah. Okay. I checked on projective processes here. Okay. And notice the way I did it. I don't know what her projection could be. It could be anything. She could project that I'm going to have be the warmest person on the planet, you know, the ideal rescuer, the devil. I mean, whatever it is, it's still a projection of a split of some kind. But what I'm doing here, as I said, is that you're worried that did you have thoughts I would be worried about you or concerned about you, or what else was it? So what I'm telling her is, I don't have any concern about my view of you, but I know you might have multiple different concerns about my view of you. You might have it, but I don't have it. Okay, so what I'm telling her is, yeah, there's all kinds of things that go through my mind. Yes, concern goes through my mind, you know, worry, irritation, sadness, these things all go through, but I'm still one whole person with all of it. And it's a bit of a way to model it for her too. Okay. So I don't just say, are you worried I'm angry at you? I have the whole thing in there to give her the idea that, yeah, many things can happen. Which one are you worried about today? Some emotions are tolerable to a limited extent, but they cause a chain reaction of the grief and the rage and guilt, and then they get drifted. So 1 second of positive and boom, they're nauseous, or they're drifty, or they're afraid of you all of a sudden. So having your eye on these things is hugely helpful for the patient. Saying it's great that we take little breaks. And what she's talking about is recapping and changing the topic a little bit and moving around a little bit, making it tolerable for her. So this again, you know, how does this model get developed? The same as the whole Davalou's work was all based on patient feedback and studying the videos on what the patient said, what helped, what didn't help, what was important, what was less important. And that's the basis of this whole model. I'm working the exact same way with these patients. You rely on them to give you this feedback. And that keeps you out of the expert position. You're not the person that knows everything. The patient brings their contribution, they give you guidance, and you share the knowledge together. Okay. And that's very empowering for this patient. The loop is broken when you can realize you don't want to hurt anyone, that you care about the people, that even when you project on them, you still care. And the guilt gets buried into more rage, more guilt, more rage, more guilt. But when you can realize you love people, you don't have to go unconscious. Nothing to worry about. No big deal. So you have anger. So you have a volcano going through your body. It doesn't do anything to anyone because you love them. And that's the thing, to get in there together. But you see, you can't do this in the early part of the session, because in the early part of the treatment, because to try to talk about this, you'll be in a mode. See, you'll be abuser, critic, judge, or whatever. You can't get there. You have to build your ability to talk about this more, bit more, build the structure of integration. Then she can start to absorb this, benefit from it, and hold this, you see? And now you can do graded format. And this, I hope you get the difference between what we started with this sort of this fragmented state, more so, and where we are moving to now. And why graded format is what you can do now. Decision here based on where we are relative to threshold. Press down lower, brace when on the threshold, recap and anxiety reduction when we're above threshold. And we're well into graded format here. So I hope you get the difference of how this feels here. It's a different thing. You have definite space below threshold to work with, and you can see what's coming more clearly. She can see it, you can see it, you both see it. You're both monitoring it. You're both activating. Okay. Patients who get really unconscious or nauseous, you got to move quick. When the rage comes up and you feel the dolphin coming up with the heat, you got to grab it and say, how bad do you feel about that, before it goes and attacks you in your body, or you go unconscious or get fuzzy. That's what I'm helping her train herself to do. Realize she has mixed feelings. That's what I'm training her mind to do.